So with that, I am going to pass the reins to Dennis Raphael. Before I do, I'm going to say a little bit about him. He is probably well-known name to all of you. He's a professor at the School of Health Policy and Management at York University in Toronto. He's editor of the book Social Determinants of Health, Canadian Perspectives Tackling Health Inequalities, which I think is in its 4th edition.
Third.
In its 3rd, okay. And then he's also editing a book called Immigration, Public Policy and Health, Newcomer Experiences in Developed Nations, and he's co-editor of Staying Alive, Critical Perspectives on Health, Illness, and Healthcare, and has a book coming out on, or is author of the book Poverty in Canada, Implications for Health and Quality of Life. So he's the guy. He's kind of the guru, and I really appreciate, Dennis, that you're here to share your work from the Health Promotion in Canada book. So with that, I'm going to let you start away.
Okay, I'll warn everybody I've given 20 minutes for this. So first, the land acknowledgement. York University is on the traditional territory of many nations. The area known as Takaranto has been taken care of by the Anishinaabe Nation, the Haudenosaunee Confederacy, the Wendat, and the Métis. It's now home to many indigenous people. We acknowledge the current treaty holders and the Mississaugas of the Credit First Nations. This territory is subject of the Dish with One Spoon Wampum Belt Covenant, an agreement to peacefully share and care for the Great Lakes region. So the plan today is to give you some thoughts that I've accumulated since 1992 when I first met Lukeman, and in terms of the different levels that one could intervene, but also to give you my thoughts on what seems to be happening or not happening. There's no doubt there's tremendous activity across Canada on all of these issues. There's so much activity that when people in Europe go to our websites, they come to visit us to see what a great job we're doing. And unfortunately, the evidence is not that great. To my perception, just about every area of the social determinants of health is not getting better, and in some cases overtly deteriorating. So I'm going to present you with a model and some updated resources, and then I'll be taking your questions. So the first thing here is, and of course I sometimes joke when you put this up in front of people and they say, God, this is complicated. Can't I just tell people to do this or that? And of course we can, but we need to recall, as Dan Nutbeam pointed out, definition of health promotion, that health promotion represents a comprehensive social and political process. It not only embraces actions directed at strengthening the skills and capabilities of individuals, but also action directed towards changing social, environmental, and economic conditions so as to alleviate their impact on public and individual health. The box at the bottom, whether we call it health outcomes or health inequalities outcome, the evidence is not great. I want to give a shout out to the Public Health Agency of Canada for these tremendous reports that are coming out on key health inequalities in Canada, for example, a National Portrait 2018. And they point out that health inequalities in Canada exist, are persistent, and in some cases are growing. Many of these inequalities are a result of individuals and groups' relative social, political, and economic disadvantage. So we begin with the fact that there's health outcomes we're concerned about. We all recognize that people are embedded within their families, especially children. So the next box up takes us to family determinants of health, and I have quality of life there. And of course, Michaela Benzavel, a long time ago, pointed out there are three key pathways: material and social resources, psychosocial environment, and behaviors. And the sad reality is that for many people that say they're working in health, they don't move beyond behaviors. So if you imagine we draw a big circle around behaviors and stop there, that's where an awful lot of people are, an awful lot of the media, and certainly the public. But we got to keep going to understand what is it that's shaping these family situations. We also have to recognize, so one model simply says, let's change behaviors. Another model points out that there are specific social locations in which people are placed that have differences in power and influence. And as I say to my students, if I'm a single mom and I call in and say I don't have enough to live on a minimum wage, remarkably, nobody seems to respond to that. But if I were to call from the Canadian Chamber of Commerce and complain about the possibility of raising the minimum wage, we would get people's attention. So that's something we have to take into account, who people are, why are their social locations so profoundly problematic. And then, of course, we get to the social determinants of health, whether it's income and wealth distribution, housing and food security, employment, working conditions, social exclusion, the usual shopping list, which, because they all are interrelated with each other, make the situation of living in poverty or near poverty especially problematic. There's very few people going to food banks that are living in mansions, and there's very few people that have tremendous jobs that are homeless. But of course, we used to think, when I first met Irv in 1992, I figured that all we'd have to do is point out that income inequality was growing, that homeless precarity was growing, and everybody would respond, that suddenly there'd be a groundswell. And that didn't happen, which led me, of course, to continue unpeeling the onion back and then to begin looking at issues of public policy. And if you think about little walls being between these different boxes, I think the biggest wall is between the box of social determinants of health and the next box, which is public policy. Whether we think we're not qualified to deal with public policy, whether we're afraid we'll lose our job if we say something bad about the powers that be, getting to the public policy area has been really difficult for health promoters, for many health promoters. And of course, once we get to that box, we can have a quotation by Claire Bambra that it's profoundly paradoxical that in a period when the importance of public policy as a determinant of health is routinely acknowledged, there remains a continuing absence of mainstream debate about the ways in which the politics, power, and ideology which underpin it influences people's health. And of course, we can draw upon what the World Health Organization said in its Closing the Gap in a Generation report, that the unequal distribution of health-damaging experiences is not in any sense a natural phenomena, but is a result of a toxic combination of poor social policies and programs, unfair economic arrangements, and bad politics. And once we get into this box, we could begin to see some of the profound blind spots. For example, labor policy. Canada has one of the lowest collective bargaining coverage. We have one of the weakest organized labor sector. We have minimum wages that fall well below the poverty line. And in terms of our tax policies, we're one of the least redistributed countries in the OECD. And many of us say we're concerned with public policies, but we carefully limit our concern with public policy to things that are not going to get us in trouble. Bicycle paths, the built environment is the latest focus of the Public Health Agency. But when we get into issues of wages, of benefits, of increasing precarity of work, then we begin to run into issues for which, as we'll continue up the ladder here, get pushback. And the pushback is not good for health. So we're up at the public policies box, and then we have to begin asking the question, everybody, whether it's the food insecurity people, the housing people, the labor people, all point out the public policies that would improve the health and distribution of the social determinants of health, and yet we don't really seem to be getting any positive response. Certainly, I have a desk piled up with anti-poverty strategies and programs, but remarkably, none of them ever touch upon these issues that I've just mentioned. You do not see the Public Health Agency of Canada talking about tax structures, talking about the growth of the 1%, the increasing inequity in distribution of resources. And again, that's one of the issues we have to face. And then, of course, we move up the ladder, and in the time I have, I can't talk much about the liberal welfare state, except to point out that, like the other Anglo-Saxon countries, our main ideological inspiration that seems to shape public policy is for government not to get involved. Whenever it can, government seems to want to get out of doing stuff. And if you don't want to do stuff, then nothing happens. When I first started in all of this, the argument was we didn't have the resources to do any of this. Well, they don't even bother doing that now. There's no money for child care. There's no money for housing, but we have $4.5 billion to buy a pipeline. And again, regards to the people out in Alberta on that one. So the issue of the nature of the welfare state, what maintains it, then takes us a little bit to the left, which is the box there on public support for specific parties. And with all respect for all of you that voted Liberal this past election, it was the Liberal Party under John Chrétien and Paul Martin that absolutely decimated the Canadian welfare state in the 1990s. And as Tommy Douglas used to say, we go from the black cats to the white cats to the black cats to the white cats. And the literature is very clear that all of these boxes look a lot better when there's support for specific political parties on the left. On the other side of the diagram is the issue of none of this stuff's ever going to happen unless we get the public to actually support the state role in redistribution and resource provision. If people all believe, and actually Canadians do not believe this, but we act as if they do, that government is bad and we should turn everything over to the private sector, then all of the changes, all of the health promotion activities we're trying to do at all different levels are really not going to come to very naught. And then to make things even more complicated, we have to move even higher and to say, what is it about the nature of the societies in which the social determinants of health and the public policies that create them are more equitable and health promoting? And what we see is that in the case of the Scandinavian countries, organized labor actually has a lot of power and influence, with 80 to 90% of people covered under collective agreements through their unions. But even in the so-called conservative countries of continental Europe, what we see is the business class actually buys into a lot of the stuff that I've just been talking about, in that they're concerned with solidarity, with maintaining their economic structure, and increasingly you see these conservative continental countries look just like the social democratic countries of the Nordic era. And to make its relevance to Canada, the conservative welfare states would be represented by what we used to call the Red Tories in Alberta, the Red Tories in Ontario, Danny Williams out in Newfoundland, and they're a dying breed. So that's the model, and as I say to my students all the time, is a model is only useful if it, first of all, explains how we've gotten to this situation, and secondly, whether it is useful in helping to get us out of the situation. So if you look at all of this and say, you know, in Westminster, BC, we've been able to do great stuff with the living wage, and we've really changed people's lives and made a difference, great. My reading of the situation across Canada is that we've not been making great progress, and that actually overall conditions are deteriorating, notwithstanding the 2% decline in child poverty over the last year or two, which would be great if it was due to the federal anti-poverty strategy, but probably is more likely due to the business cycle. So what does that mean in terms of the issues we're talking about and the issues that you have to deal with, especially in your jobs? And that is that ultimately we're concerned with the overall health of Canadians and, of course, reducing health inequalities, which if we think they're immoral and unjust and avoidable, we can call health inequities. What do we do at this level? This is certainly where tremendous work is done by local public health units on supporting families, family visits, drop-in centers, community recreational areas, and this stuff's really important. And the question is, what do we do at the individual level, working with individuals? What do we do at the community level? And of course, at the policy level, takes us to the next slide, or at least starts moving us up. What do we do specifically in terms of individual interaction, community activities, and policy to help people in specific social locations? And what I see here, is somebody whistling back there? What I see in terms of some of the people that signed in, the person from Hamilton, for example, tremendous work is done in the Anti-Poverty Roundtable in Hamilton, and of course in other areas as well. But in terms of my model, then you move to the next level, and that is, what do we do in terms of the social determinants of health and for quality of life? What do we do in terms of income and wealth distribution, housing and food security? And here we kind of leave the individual level, and we see all the really good work being done at the community level across the country, and we see also the stuff being done at the policy level. But the evidence indicates that things are not getting better, that income inequality is certainly not declining, in some cases getting worse. Precarious work is frightening. If I was a millennial or someone who was born, my kid's 19, I'd be terrified of the future. Employment and working conditions are deteriorating. Certainly we have concerted attacks on health and social services that really remain unabated. If we then move to the issue of public policies, this is where I see both the possibilities and the dangers. Because what could be more influential than a medical officer of health, whether they are an individual medical officer of health or the organization of Ontario Medical Officers of Health, who back during the Mike Harris era said to me there was nothing they could do about anything. What do we do to shape public policy? Do we put evidence out? Do we try to shame people? Do we put out statistics about excess deaths in each area or neighborhood, which is what the Brits do? And this is the real dilemma. What do we do as a public health community to really constantly remind powers that be that they have a responsibility to support the health of the greatest number of people? What can we do in terms of educating the public? And again, here's a big shout out not only to Sudbury, but to all of the 20 other health units that have taken their video, and some of you across the country as well, on Let's Start a Conversation About Health and Not Talk About Health Care at All, that is really trying to educate people about how health requires a state role, although they wouldn't use the word state role, but they require that governments actually work to shape the distribution of the social determinants of health. And this one's a bit more tricky. I mean, I'm trying for 10, 15 years to get my political party to take any of this seriously, and they won't, and they don't. And of course, when people do take it seriously, they get into power and get into cabinet, and then we see what happens to them. And I won't mention Jane Philpott's name, although I did. And then we move to the next level, and this, you can well imagine, is not the kind of stuff you're going to do from your 9-to-5 job. And that is, how do we fundamentally shift the balance of power and influence in Canadian society such that we can even out some of the forces that are shifting public policy in a direction that's not particularly favorable? Now, there's a whole bunch of arguments about why we can't do this. It's not good for the economy. Conference Board of Canada points out the Scandinavian countries' economies do better than ours. We can't do it because we're multicultural and because some of us are black, yellow, brown, and white. We all cannot come together and have a good welfare state, which is not accurate. The fact that our population is too spread out, actually our population is not spread out at all. It's all concentrated along the border. And Norway is ultimately more diverse. And there's this litany of course, we're now as wealthy as we've ever been. So it's not a question of the economy can't handle it. I think it's ultimately about power and influence, and a lot to be said about who's laughing all the way to the bank. So finally, I'm just going to conclude here by pointing out some resources that are out there. Fran Baum's stuff on cracking the nut of health equity argues you've got to have bottom pressure going up and top pressure going down. I see very little evidence of top pressure, so it suggests even more important is the importance of community action to somehow force change. Proportional representation would turn public policy around on a dime in Canada, because you would never have majority governments dominated by one of two business-oriented parties. And in fact, S. Pete Anderson argues that the social democratic miracle in Scandinavia was a result of them having proportional representation as early as the 1920s. Resources, there's certainly no shortage of material. Irv's book. We have the 2008 Closing the Gap report. We have, click on the right button here, Ryan Maeli, Upstream, wonderful organization. If you live in Saskatchewan, send him money, because he actually ran his leadership campaign on a healthy society and the implications of addressing the social determinants of health. Canadian Medical Association's on board. This has now been downloaded 1 million times, and Yuhar and I and Tober Bryan are in the process of the second edition, hopefully out soon. A little book I did, which is small. The worse things get, the more there is to write about, unfortunately. Tober's book on health policy in Canada and policy change. This book is a real eye-opener. William Carroll out in BC on how the 1% is able to organize and use its power and influence to shape stuff. And this was a really interesting book because of that movie Taxi. I forget the exact, but about a taxi driver in Toronto who was a doctor and has a happy ending, and usually is not happy endings. But we have a chapter in there by Eileen, the immigration guru. It'll come back to me. And then this one, the mother of all social determinants books. Poverty in Canada, new edition will be out in 6 to 8 months. This one was a lot of fun because we got to compare the liberal political economies to the Scandinavian political economies. And, this one will be out next month, the latest edition, which has a lot of interesting stuff. So apologies for the book ads, but they don't pay me for this. And I'm here. I'm not going away. I was just out in Kelowna a couple of weeks ago. BC really is beautiful, I could tell you that. And thank you, and hopefully I did my within 20 minutes.
You're pretty good, Dennis. You
good.
2
Thank
minutes
you.
over, but I think we can allow that, actually.
All right, I'm done.
I did have a question asking for the citation for that, the table, the graphic that you went through with the different levels.
Yes, can I type it in the chat box?
Yeah, that would be great.
And yes, I know exactly where that is. It was an article in Social Theory and Health. And if I go, will I screw everything up if I get it and retrieve it?
No, you go ahead.
Okay, I'm going to go do that. Thank you.
Yeah, no, thank you. And just before I introduce Sionnach, I've had a couple of people also ask if we can share references and resources, and so I will do a follow-up email for folks sometime before Christmas, so I won't promise it soon, but it'll be before Christmas, and I'll do the quotes, and I'll do any information or resources that come up in the chat box.
One of the things people might want is a copy of my course outline that I have a course called The Political Economy of Health Inequities.
Sure.
And,
if you're able to share a link or a copy of that, I can certainly, if you're
yeah,
okay
I'll
with
send
that,
it. I'll email it to Diane because there's no link. It's not sitting anywhere. But
right.
I'll take care of that, and that'll be, Diane will have it by, this afternoon.
That's great. And also, people are asking about a recording. So this webinar is being recorded, and we will be posting it on our YouTube channel. Maybe Asher can pop the link for our YouTube channel up in the chat box. And I don't know exactly when. It's usually within a few weeks. So what I'd suggest is just keep checking back over the coming weeks to see when it's there. And that way you can use it for continuing ed, staff discussions, your own personal knowledge, and you can recommend it to others. I know sometimes they're used for course content as well. So yeah, so that's that. So Dennis, thank you. You never fail to say it like it is. And I really appreciate very much the challenge to think about power structures and what we can do on a policy level, and I think that's hard. I was in frontline practice for 16 years, and I think it's really hard for some of us to figure out what to do, so I'm hoping this is giving people ideas.